Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and we're speaking tonight with Dr. John Geyman, one of the founders of the Specialty of Family Medicine. Also with us tonight is Dr. Aaron George, a faculty member at Meritus Family Health in Hagerstown, Maryland. I hesitated there for a moment. And Allie Abel, who is a fourth-year student at the Albany Medical Center at Albany, New York. And Aaron, I'm going to turn things over to you and Allie, and I'll be involved as appropriate. So, okay to turn things over to you?
Sure. I think the best place to start is just to offer some familiarity with the group. And Dr. Geyman, with all deference to the fact that I think that you're an absolute celebrity in our discipline, I think the most important person on this call is Allie, and I would love for her to start by sharing where she is and her trajectory.
Good.
Hi, everyone. I'm Allie, third-year medical student from Albany Med. Currently have wanted to be a family physician since earning my MPH in 2014, knowing that primary care is really important in this nation. So I am so excited to be on this call with so many great people in family medicine. And John Geyman, thank you so much for offering your time.
Yeah.
And for myself, I'm actually I'm Aaron George. I grew up in a small rural town in southern Pennsylvania and wanted to decide if I wanted to be a college professor in history or a physician. I had the opportunity to study the history of medicine at James Madison. And taught U.S. history for a year, and then went off into medical school and thought I'd never see history or history teaching again, and wound my way around into private practice back in my hometown and practiced there for about 4 years. And along the way, having conversations with Larry, he had picked up on some of the interviews he had done with yourself and some of your colleagues on the visions of the founders, and kind of re-engaged some of that desire I had to understand a history and to refocus it for history of family medicine. And so I know there's been a lot of good work at the center in Kansas City, but we went about diligently over the last 4 or 5 years, interviewing as many different founders as we could, and picking up on some of the topics that you had interviewed as well. We had originally started asking the questions about what was the vision at the time of the founding of the discipline, and what was some of the themes and goals of the discipline. And more recently, we've involved myself again as a relatively young family physician, now 5 years removed from my own residency graduation, and Allie, who's a rising medical student and a young national leader in family medicine as well, and thought, how do we take some of those early visions and discussions and actually start to reframe them for the future, and maybe look to see what are some of the things that were realized or left unrealized, and how can future leaders like ourselves, and again, I said Allie is the most important person on the call, and as a medical student, this is the field she's inherited, and she has a chance to impact it. And so, Dr. Geyman, we wanted to reconnect with you now that we've gone about close to 30 interviews, and kind of shift the conversation from what I think when you and Larry had spoken originally, and discussed the visions at the outset, and really shift, if you're willing to, with us tonight, onto what the future of family medicine could look like, and how we can take the past to help frame our future. So I'd just like to start and to open up and return back to some of the original discussions you had several years ago with Larry, and just ask, as you recall, can you briefly talk to us a little bit about some of the dreams and visions of the founders of family medicine?
Yes, I can. First, a little background. I went to medical school at UC San Francisco from 56 to 60. I wanted to be a family doc from the beginning. There wasn't a way to train very well, but so you had to put together your own program. I interned at LA County, which is the second biggest hospital in the country then, second only to Cook County, with 3,500 beds, rotating internship, which I liked a lot. And then we did have some general practice residencies around the country, mostly in the West. There were some good ones. They were 2-year programs. And I found one at Sonoma County in Santa Rosa, California. Went there for excellent 2-year residency where we learned everything from anesthesia to some surgery and orthopedics and lots of emergency work and on and on. And then again, I always wanted to be a family doc, so I wanted to go rural where I could make a bigger difference. I ended up in Mount Shasta, California, a small logging town up north for 6 years. Then family medicine became a specialty in '69. And then I figured that family docs ought to be the ones running these programs. So I went back to Santa Rosa and set up under a regional medical programs grant, a 3-year family medicine residency from the 2-year GP residency. Then I tried to hook on, and we did an affiliation with UC. I tried to get UC to get a Department of Family Medicine. No, they weren't ready for that and weren't for another few years. So I went to University of Utah and was the chair of family medicine and a division of family and community medicine at Utah. And a couple of years, and then I came back to UC Davis. 5 years, developed a residency network up and down Central and Northern California. And then I went to University of Washington as the second chair of family medicine there at University of Washington in Seattle. Did that 14 years. Then I went back to rural practice up here in San Juan Island for 7 more, and I've done full-time research and writing on healthcare systems, and I'll come back to that since 1997. I practiced 7 more years in Freddie Herbert, Washington. Anyhow, so I can talk as you might want to hear about what I and others, including Gail Stevens and others that I worked with earliest years, what our vision was, what we wanted to see, and then I can compare it with what we have now and talk about that. But the biggest single thing I will say, and it comes in all my writing and work, is we're doing pretty well in family medicine, but we are in a terrible system which is working against our goals. I would like to see family medicine as the foundation of our healthcare system in countries where primary care and mainly a generalist role is the main foundation, like the UK, which is 40 or 50% GPs, and like Canada, which is, well, less than that, but at least 30%. Here we are with 10% graduating into family medicine residencies after all these years. So, but the system is against us. It reimburses. I can go on and on about this, so I'm going to stop right now.
Well, I think that is an excellent introduction, and I would love to fill several hours talking about everything you just said. So I think you've got a lot of friends and allies on this call that would definitely agree. And thinking back, especially, I'd love your insight as you talked about the 2-year GP programs that you were a part of, and then laying those seeds and the foundations for programs throughout the West. Do you recall some of the maybe conversations and discussions leading up to and then around 1969 about as the discipline was being crafted, about what kind of the vision for where it's situated within the healthcare system then and maybe the future would look like?
Well, I think most of us then wanted family medicine to be the foundation of our system. That was our vision. And as the main generalist field, and general internal medicine and general peds took up the gauntlet some, but then in later years, many more subspecialized, so that hasn't been too big on the actual primary care base. So, but let me just give you a sense. When I went back to Santa Rosa and wanted to set up my own family medicine residency, the first thing I did was go around the country and visit 6 or 7 programs. And Gail Stevens was the first I went to in about 1970, Wesley Medical Center in Kansas. I'll come back to that in a minute. And I went to Oklahoma, and I went to Florida with Lynn Carmichael, and up to Medical University of South Carolina with Hiram Curry, who was a neurologist, but he had the vision. And then up to New York, and up to Ian McQuinney in Western Ontario. But the first place I stopped was Gail. And I want to tell you this, you'd be interested in. The first place he told me was not the Family Medical Center or the hospital or anything like that. He took me to the library. And we had an extensive tour of the library there. Well, he was a writer, he was a scholar, he was a great speaker, but he lived a lot in the library, which I found that's what I ended up doing too. Or now we have internet, so I don't have to go to the library that much. But anyhow, that's a clue to Gail.
I'd love to hear if you recall any more about that story specifically. When he took you to the library, was that to share some of the studies he had found? Was it to share the community? What was kind of his goal in bringing you there?
How important the written word is, and also we didn't have a literature of record in family medicine. We had to start from scratch, and that's where actually I founded the Journal of Family Practice in 73 and 4. I actually wrote the first book on family medicine, The Modern Family Doctor and Changing Medical Practice. And that's a story. I wrote that when I was working in Santa Rosa developing a family medicine conversion from GP. And I sent it to 3 publishers in the Northeast. They all rejected it out of hand. I then sent it to Appleton Century Cross in New York City, which is the second oldest publisher in the country. David Stires was the publisher. His dad had been a GP in a small town in Ohio. He took it right up, published it. We became friends. We worked together for years. We founded the Journal of Family Practice. We had in 73, started publishing in 74. But we needed a literature of record, and there wasn't anyone. The American Academy of General Practice had their own journal, GP, and all that was a CME journal. There was no research in it. So we envisioned a scholarly journal and a clinical journal too. And that's way back. I edited that for 17 years. Then I went on to the Journal of the American Board of Family Practice for another 13. So I edited journals for 30 years because I think the written word is really important. And we were trying to develop our literature of record. And I can tell you, I have in front of me, what was the first issue of the Journal of Family Practice? In it was the future of family practice in our medical schools on the teaching and learning of clinical wisdom, which Gail Stevens wrote, peer review of a small group practice, a competency-based curriculum in family practice residencies, a survey of psychiatric care in family practice, an integrated system for the recording and retrieval of medical data in a primary care setting, and primary care research in a model family practice unit. That was in the spring of 74. So that's where we started.
You know, it's amazing as you read off that list. I don't think that would be far-fetched to share with you a list and say that was published last month in a journal. Those titles seem like they're exceedingly relevant even today.
Yeah. Oh, and here, I wrote an article myself in 2013 for Family Medicine, that journal, and as to trying to answer why do we write. And my three things in that article was, one, to learn more than we know at the start of a writing project and to share new knowledge with readers. Two, to advance our specialty and to add new information that's true, important, and of value to readers. And three, to examine questions or issues related to our profession and the health of the public. Let's see. And four, to clarify complicated subjects by cutting through to the essentials. Oh, yeah. Next page. Five, to bear witness to the problems being faced by our patients during the current health crisis. Yeah, and this book I wrote in 17. And six, to expose conflicts of interest that run counter to our patients' interests. And seven, to advance the common good. So, I mean, Gail taking me to the library early on was formative for me. And I think we need all this big time now.
So one of the themes that come out. Oh, go ahead, Allie.
Yeah, do you mind if I just ask you? So as a young medical student and resident, and then a young physician, how does one, I know you did it as a young physician, how does one make time to be a writer and to be a good diagnostician? It seems like a lot, and I know that I really, really want to be a good writer as well. So what are your, how would you mentor somebody like me?
It's a huge challenge. I can tell you that I wrote that first book, The Modern Family Doctor, at night on the kitchen table in Santa Rosa after working all day with a very small faculty of just several people early on. So, you know, you do it on your own time. And my first article in a very busy family practice in Mount Shasta, I saw a prima gravida patient with these bluish eyes and her first visit, and oh yeah, osteogenesis imperfecta. But what I didn't know how to deal with the pregnancy or the newborn. Here I am in rural practice. There's no internet. I flew down to San Francisco and spent a day and a half in the library at UC. Came back. Well, first of all, I called a consultant in our nearest place, 65 miles, and then a classmate who was a fellow in OBGYN at UC. They didn't know. So I flew down and got what I needed, and that was my first article, which I wrote at night. So you can, even if you're snowed in practice, but it's uphill and it's hard.
Wow, that's awesome. Awesome to hear. Thank you.
But now it's harder because I go into all this, and you know all this. And Aaron, you've been practicing for 5 years or plus. So, but now 2/3 of docs in the country are employed usually by hospital systems, and they're under the thumb to upcode from administrators and blah, blah, blah. So the pressure is intense to see more patients and bill higher. So it's a bad system we're working in. I remember about 15 years ago, don't remember the exact year, but one of those later Keystone events in Colorado, and someone summed it up really well. It's hard to practice what we're trained to do in a bad system, something like that.
I'd love to. Go ahead. Yeah, go ahead, Larry.
Well, I'm just wondering if I could interrupt for a moment and pick up on that point. So, Dr. Geyman, I started in 1978 with Tom Lehman, and I knew Hiram Curry and Gail Stevens and Ian McWhinney, you know, from going to STFM meetings. I can't say that I knew them well. I knew Tom very, very well, right, because he was my department chair. But
Yes.
my sense of those people is that while it was an uphill battle building family medicine, I don't recall them feeling trapped. Now people are, as you say, they're employed by hospitals, and I have a sense that people feel very trapped, and there's a certain hopelessness that comes with that. And I'm wondering if you could perhaps, would you agree that you and your colleagues, the founders, didn't really feel trapped, that you felt hopeful, as opposed to where the stuckness that people have now? Is that a fair observation on my part?
Well, I think back, I think it was exciting. And we were hopeful, but we were just stressed to the point that we wanted to get it all done quick. so,
Right.
But not the kind of burnout stress that's going on so widely now. So we felt more in charge than I think a lot of docs do now. And just to put a side point on this, and I did this at University of Washington. I was always trying to get our other faculty and residents and students interested in the whole healthcare system and becoming advocates for real reform. I mean, if we want primary care to be the base of the system, we got to work on it. And so, what are the impediments? And meanwhile, learn more about the system. And so, I think that's a key point everyone in family medicine should become engaged in as an activist towards that goal, and as an activist on behalf of your patients. Yeah.
So I'd love to know a little bit more as you were discussing those ideas of embedding family practice as a foundation in the system or a linchpin.
Yes.
And do you recall any conversations about what that looked like in terms of maybe not metrics, but a percentage of the workforce, those family physicians, or a percentage of the total cost of care that was attributed to primary care? Did you remember talking about any kind of goals or specifics, or was it just build this so that it exists as the best foundation possible?
Well, we haven't had a national physician workforce plan. We don't have one now, and we've never at the national level set a goal for real primary care, which in my view would be family medicine. And so we never addressed as a country, as a healthcare system, that number. But based on my own research, I know that in England it's about 50%. The last thing I've heard in Canada, where they have an effective family medicine base, it's at least 30%, might be more. Other countries, a few others have stronger primary care, but we're weak here, and so it's not become a policy for the workforce, and it should be.
So let me just jump in again.
Yeah.
I'm wondering if you have any thoughts. So you've been in University of Washington, certainly is a prestigious organization, medical center. Do you have any sense on what it might take to get the academic leadership, the deans of medical schools, or at least most medical schools, to agree with you on that and begin actively lobbying for, advocating for such a goal? Do you have any insight on that?
Well, I've been there, and I know the dynamics of the fights between clinical departments and medical schools, and the whole medical school. The dean has to deal with all these rival departments in his school or her school, and usually succumbs to the most powerful voices and to the flow of money. and so if you're in surgery and orthopedic surgery and radiology, these are very, very highly reimbursed. Again, we're right back to the system, and the fields that are poorly reimbursed, and that's a whole subject. It comes back to the AMA committee on setting
Right.
codes and all that stuff. But psychiatry is in big trouble. They're under reimbursed. Geriatrics is, family medicine is. But money talks around a medical school, like you can be sure. So again, it comes back to the system. And for me, I'm a strong member of Physicians for a National Health Program. I was president of that, PNHP, in the early 2000s for a couple of years. If we had that, we could rein in the prices. We could negotiate fees among specialties and put primary care way up there and psychiatry. But right now, it's a free-flowing market system, and money talks.
Mm-hmm.
So I would encourage both of you big time to become activists and to join PNHP.
And what about forces outside of the medical school? Back when you and the others were founding the specialty, you had some energy that came from rural constituents, from state legislatures in many states,
Yes.
and perhaps from others. And I keep thinking now that we're way too isolated, and we're trying to fight this battle alone. So I'm wondering, do you have any thoughts about those outside forces and how to either connect with them or tap into those energies?
Well, I was fortunate, and it's partly why I went to University of Washington. It was in 1970 that they developed the WWAMI program, Washington, Alaska, Montana, and Idaho. Now it's Wyoming in there too. But in the 70s and 80s and 90s, WWAMI, that's a quarter of the land mass of the U.S. And so a lot of rural country in those 4 states, and so they need family docs. They don't need a lot of the other fields. And so that was a big push from the state legislatures and the dean. We had a really good dean then who supported all that. He came from Kansas originally. And so that was very formidable, and it still is. So we have now 5 states supporting the education of medical students and residents out in their own states. They're partly involved. They are involved with the medical school admissions process. They're trying to get graduates of UW programs back to their home state and not go elsewhere. So it works, and there are other networks around the country. If you can get those set up where you are, that's strong. So, but circling around, I think that our system is very dysfunctional. It's become very unaffordable, and access is limited. The quality is way below what it should be. So patients are hurting, and I think if we can just get a national move to rebuild on primary care, again, through Medicare for All, there'll be global budgeting of hospitals. Rural hospitals can start surviving. They're not now closing like med. And family medicine can do a lot better, and we can recruit better to family medicine. And then there's another pressure I haven't mentioned, and that is the policies of reimbursing hospitals, teaching hospitals based on specialty reimbursement, and that favors the other specialists, not the primary care ones. So that would have to be looked at too, the whole financing system of graduate medical education. Yeah.
Aaron?
I guess in terms of how the discipline of family medicine is delivered. So
Yeah.
even if we have less of the workforce than we'd want and the less of the finances we want, in the areas where it's done well, do you think that the visions of the founders, from at least how the practice of family medicine is integrated, how care is delivered, the scope, the training, do you think that we've at least realized those goals, even if we haven't realized the magnitude, perhaps, of the impact on the system?
I think so. I think we have a lot of strong programs around the country. I'm in favor of programs that are and include OB training and our broad breadth training. Out here in the Northwest, we have a number of strong programs where they can place their graduates out in rural communities, and they'll become the hub of those communities. So that's the goal. It is achievable. It has been achieved for quite a long while. And so it's just that there aren't enough of us, and that we're fighting uphill in a system where, again, back to Keystone, it's uphill. And it doesn't need to be. If we had a third of the docs in the country in family medicine, and let general medicine and general peds go into their subspecialties, which they're doing, like 75 or 80%. Well, okay, let them do that. But we need to become a high priority in a new physician workforce plan. And that, by the way, is part of the House Bill 1384 for Medicare for All, being supported by Pramila Jayapal and Debbie Dingman from, I think, Indiana. So, yeah. So we have to become politically active.
Do you think that political activism was at the roots of the founding of the discipline as well? I mean, one of the conversations or the words that we've heard over and over again is kind of this counterculture, this revolution. I think activism is something that's been thrown in often, and it was a response to an institutionalized system. Did you feel that way, that there was a bit of activism at the outset?
Oh, I think so. Sure. It was a triumph to get family medicine as a 20th specialty. That was a triumph in '69. Yeah, and so it came off a buoyant enthusiasm to now let's develop our training programs and, let's do what we know we can do and what the need for care is. Yeah.
So then I have actually a good bit of hope as we're working through this call, and it just really makes me feel good to be a part of this. So myself, I'm an assistant program director at a program that just started this year, and we've launched from the ground up. And part of these discussions that I've been having with some leaders like yourself has been to understand where we're coming through and then try to embed that philosophy in the training for the future. And so I've really enjoyed these calls because it's helped me to ground some of the basis for the family medicine residency that I've been designing. And it makes me feel really good to hear you say that when you look at how we're delivering care, how we're integrated as within community-based care, the scope of practice, our research, our writing, that all of those things are still in line. So we haven't necessarily shifted away from what it sounds like were some of the early discussions. And if it becomes numbers and workforces and finances, we don't have to change who we are. We just have to change how the system sees us. I don't want to put words in your mouth, but that's what it sounds like.
No, that is true. I think where we are is just fine. There just aren't enough of us, and the system is not welcoming us. Just a comment around the edge. When I was in practice in Mount Shasta, I was in solo practice, worked 80 hours a week, loved it. Anyhow, and I saw Medicare and Medicaid being introduced in 65, and it was seamless. People would come in with their card, and I could ask my first question, how can I help you? A couple times I asked, what brought you here? And after I heard a guy say, well, my blue Chevy truck. So I didn't say that anymore. But now you never hear that question. The first question from a reception desk is, what's your insurance? But if everyone has universal coverage, that won't be the first question. Yeah.
So then as far as the goals that I've heard from you then really are, how do we become activists? How do we influence policy? And how do we change financing in our health systems?
Yeah.
So that would be shifting the way that we empower our own and the way that we engage those around us. I think those would be the two things I would imagine would allow us to be, as a discipline, to be stronger advocates for ourselves and for our patients.
I like that. Yeah.
Have you thought about at the national level how the specialty can do that, or I'm sure you've thought about that a lot over the last couple of decades. So that's a very open-ended question, I suspect. But
okay,
do you think we should be doing?
Let's start with our academy, AAFP. They actually disappoint me a lot. As you gather, I'm pretty candid. And we had about 4 years ago, a president of the academy from Denver University there, and he was a single payer guy, and I had great hopes that he could do something as the president of the academy, and then after that on the board. No, and I recall going to national academy meetings, and here's this big bazaar, all this huge room with all the pharmaceuticals, and the academy is bought off by pharma. Well, and they've never come forward with any national effort to reform our system. So I'm very disappointed with our biggest organization.
Dr. Geyman, what would you suggest for students and residents? Should we be getting involved in our state chapters? Like, what's the best way to become activists for us?
There's this organization, Healthcare for All. There are two organizations that I would join if you're not in them now. Physicians for a National Health Program, PNHP, based out of Chicago, state chapters all around the country, founded in 1988 by Drs. David Himmelstein and Steffi Woolhandler. They're still at it. They're based in Cambridge. They're terrific people. They know the history of all this, and they're ongoing activists despite all these years later. So join PNHP, and they're, again, chapters all over the country. And then Healthcare for All Now is another organization, and it's all over the country too. And right here in Washington State, for instance, a general surgeon from Seattle is the coordinator of that, but it's a very active Northwest chapter, and they have links to the legislature legislature and are activists within the state and the state level. So healthcare for all now is another group that would be very effective for you.
Great. I'm looking up actually right now. That's awesome.
Yeah.
Okay, cool.
And that crosses all specialties, by the way, there.
Good to know.
And Physicians for National Health Program does as well. Oh, and now, here's another thing. Write this down. Don McCann is a family doc who practiced in Orange County, California for 35 years. He was president of PNHP before me. And for the last 15 or 18 years, he spends full time doing a quote of the day, Monday through Friday, and get on that quote of the day. In effect, it's a graduate course in health policy. But he works every day getting sources of research that's relevant to the future of the healthcare system and to the problems we have in healthcare, be it access or cost or quality or what to do. And he draws from national and international studies and all kinds of places. But here's his email, Don at McCann, MCCANNE.org, Don at McCann.org. But just get on that and ask to get on the mailing list, email list for quote of the day. And that's great. I mean, that's
wonderful.
In 5 minutes, you can get all kinds of information that's really pertinent.
Great, thank you.
So
have
I'm
I
going to
thrown
ask
too much? Have I thrown too much at you?
I think we're all thinking you've stirred up a great deal. So one of the things that I wonder about is the potential of a union, if you like, between family physicians and others who share the vision that we're talking about, and patients broadly speaking. I'm aware that in a market-driven economy like ours, consumers, patients, have influence that if they value a service, if they want a service, they have the potential to influence policymakers, insurers, et cetera. And I wonder if you have any thoughts or maybe any experience with influential, and I'm not just thinking about every patient or consumer, I'm thinking about what I call people with agency who might, people aren't happy with the system as it is now either. And I'm just thinking about how do we create the broad base of support for system change.
Right.
Any thoughts?
Well, I think, again, Healthcare Now can put together groups in your area, including ties to legislatures. But yeah, I think you're on the right track. How to do it is a question. How other ways to do it.
I was hoping you'd have all the answers.
No, I wish I did. Yeah, but you're right. I'm pretty sure that the public increasingly is going to become totally unhappy with our system. It's already happening. I think it's going to happen even more. I mean, look at the devastation of this coronavirus
Right.
pandemic, and we're so far behind the curve, and I think also we haven't touched on this yet. I think we've been bad as a system, and often in our teaching programs, not to involve public health more. And so I would look for allies in public health as well.
I completely agree with that.
Yeah,
Yeah.
yeah.
So I will tell you that I've talked to a couple of family physicians in different medical schools who teach in the School of Public Health in their respective schools. And they believe that within that group of students, those are the ones, if they desire to go to medical school, those are the ones most likely to be attracted to family medicine once they get into medical school. And so I'm thinking you're right on with your recommendation that we build bridges there.
Oh, yes, I think so. I'm not surprised that you said they are more likely to attract to family medicine as well. Yeah. Yeah. I mean, and we share the same values in family medicine. And it's not to make money; it's to make a difference, and
Right.
and not just for individual patients, but for population in our area, if we can. So I've always been interested in, okay, here I am in Mount Shasta, so what are our big problems? Well, I can practice one-on-one medicine and family medicine. That's great. But we had a big problem. We had 4 communities around our Mount Shasta, which a 28-bed hospital we had there, but we had a community 12 miles to the east, McLeod, and 8 miles to the south, Dunsmuir, and 10 miles to the north, Weed, and we had a lousy emergency care system. Each small town had its own crummy ambulance, not well trained, no good communication system, but so I was always trying and formed a committee to let's get a system much better organized and with good communication and better training and all that. And it never happened when I was there, but 3 or 4 years later, it finally did, and it's a good system now. But the point is, you look where you are and what are the problems in the system, your local system or whatever level, and so I think that's how we should practice.
Dr. Geyman, I'd love to just ask a little bit more about things that you're proud of. I think it's really easy. We're all problem solvers, and we look for the faults in the system and things that we can work on.
Yeah.
Are there things that you look back on and are really proud about where we've come and where we are right now?
Yeah, I think we have a lot of excellent teaching programs, including the graduate level and CME. We have a lot of great people in family medicine. Commitment is high among most of them. We're just too small in the system. And so I think that's a great ongoing result, but we just need to become more system-oriented in terms of improving the system. And I think the odds of that happening are increasing quickly now, especially if we get a Democratic House and Senate in 9 months, whatever it is. And especially if we pass Medicare for all, and especially if we develop a physician workforce plan. And that House bill, as I told you, has building primary care right in there. So, and reform of reimbursement. So a lot can be done, and I think it's going to happen because the public is losing big time, and increasingly so. We have 30 million uninsured. We have 87 million underinsured. I mean, it's really bad. But that makes it more challenging and more motivational to do something about it.
Well, again, I'll reiterate. This is really refreshing to me. It's good to hear. Again, especially as one of the educators that's looking to try to decide how to train the future of family medicine. And I'll share with you, developing activists, developing those that are skilled and engaged in advocacy and make it a part of their professional obligation is at the heart of what we're looking to do in our training. So it's nice to hear you say that seems to be first and foremost one of the things that we need to be inspiring in our future family physicians. And I see it around the country when I connect with other family leaders. So Allie, I don't know how you feel about it, but I want to at least offer kind of the perspective from this generation that there are a lot of young family physician leaders that are very talented, that are very eager to be advocates. We just have to not break them.
Yep.
I agree with you, Aaron. We actually at Albany Med, we're right down the street from the state capitol building, and never before did we have like a formal advocacy track for students. But now we just started, our class president actually is going into family medicine, and he just started an advocacy student interest group, and they lobbied at the state capitol a few weeks ago. And I've also had the pleasure of going to the National Congress of Delegates, as well as my state Congress of Delegates. And every single medical student there's a ton of medical students that get up to the microphone and bring resolutions to the floor. And it's awesome. And that's exactly why they want to go into family medicine is I feel like all my classmates and the residents that I've met are very socially minded people, and they want to create those relationships in the exam room, but they also want to do things at the community level as well. So I think that's what our generation of family physicians are excited about.
And again, the student AMA got the AMA to study single payer, right, out of their last meeting. And it, so there's a lot of activity there that's dynamic.
But I really want to be respectful of your time, and I'd like to, before closing it all, I would like to ask you, are there any things that we didn't ask you that we should have?
No, I think you've asked all the right questions. And we spent a lot of time on system. Well, that's what we came down to. We had those 4, whatever it is, in Keystone meetings, which were very productive. And, but we often complained about it's the system, and so that's where we start to make the system better, and it can be. And some states will come along better than others. And again, to summarize though, get on the quote of the day with Don McCann. Consider joining PNHP and Healthcare for All -now will give you allies, not all physicians too, but allies and directions to state legislatures. So those are pretty practical ways to go forward. Also, Aaron, can you and Ellie, can you give me your emails and mailing addresses? Because I want to send you. I'm working on 2 books right now, which will be my last book. But so I want to send you those. So Aaron, what's your email?
Wow.
Mine is AARON E as in Edward, so it's my middle name. So Aaron E. George
GEORGE
at gmail. GEORGE at gmail.com.
Okay. And what's your mailing address?
My mailing address is 20241 Huntington Court, and that's Huntington with a T at the end, so Huntington Court, Hagerstown, Maryland, HAGERSTON. Hagerstown, HAGERSTOWN.
Hagerstown,
Maryland.
New York. Oh, Maryland. Yeah.
Maryland. Yes, Maryland.
Yeah.
21742.
Okay. Let me repeat it back. 20241 Huntington Court, Hagerstown, Maryland 21742. And your email
That's
is
right.
AARONE George at gmail.com.
That's perfect. Thank you.
Okay. And Ellie, yours.
Yeah. My email is A, B as in boy, E, L, A, so it's Able A, at amc.edu.
Okay. ABELA at amc.edu.
Yep.
Okay. And your mailing address.
It's 571
Yep.
Park Avenue,
Okay.
apartment 2.
Apartment 2.
Yep.
Yeah.
And then that's Albany, New York. And the zip code's 12208.
12208.
Yep.
12208. Okay.
Yeah. Thank you so much. I'm so excited.
Yeah. Okay. No, I think your questions were right on.
Well, I just have to say this really is an absolute pleasure. I again in my time learning about family medicine, I want you to know I've read so much of what you've written, and so the time and effort that you put in on those nights coming home from a late clinic have resonated through years, and I want you to know I'm kind of tearing up thinking about this a little bit because I know how much of your heart and soul you've put into this. But know that you're influencing many more people than you probably have a chance to speak to. And so there's people like myself who are out here that are reading what you've written and it inspires them. So the time that you spent with us tonight it's so meaningful for me. And I want you to know from here, Allie and I are actually applying to be fellows to the Center for the Study of the History of Family Medicine in Kansas City. And we want to take some of these collected interviews that we've done and try to reinvigorate that vision, share it nationally with young future leaders in the profession, and try to inspire them to seek out leaders and family physicians in their own communities and their departments and have these same conversations. We want to kind of inspire this sort of discussion to resonate with others around the country too. So thank you for being a big part of that.
Well, very good. Glad to hear that. And I'd like to see that that effort be more vigorous. Yeah.
Agreed.
Larry or Allie, do you have anything to add or anything else?
I don't think so. I just I want to reiterate what Aaron has said. Is my hope is that that energy of the young who've got they're just beginning their careers. They can take this over the top, so to speak. The founders built an incredible base, what we have right now. You know, and I will tell you, Dr. Geyman, one of the other things that I've been doing is trying to help the young know just how much the founders did. They don't appreciate what medical schools, what the practice of medicine was like back in the day, so to speak. And you and your colleagues came along, you transformed everything that you touched. Medical schools are different today by a long shot from even when I started in '78. They're much different. And family medicine and your energy helped that to happen. And now we need the next generation, these young folks who are well trained, to take it and with the advocacy like you're talking about, push it over the top. So that's what I'm hoping will happen.
That's great to hear, and yeah, right on, Larry.
And,
Yep.
and Dr. Geyman, if you have any suggestions on people we should be talking to as we really take off with this project, if you have any ideas, please let us know.
Okay, like who else to interview?
Yeah.
Within the rubric of what you've been doing so far, right?
Yeah.
Okay.
Yep.
Okay, let me think about that.